All right, by my computer, it is 9:30. So I want to go ahead and get this session started. I want to make two quick housekeeping notes, and then I will turn it over to Dr. Pena. First, I think since you have all gotten into the session, you recognize this, but at the end of each session, we will be logging out, and you need to go back into the Cadence platform to go to your next session. We will do that at the end of every session. So don't be alarmed if you are abruptly cut off and have to go back in through the platform. That allows you the freedom to choose which sessions you want to attend. Secondly, just a reminder, evaluation links are specific for each day. At the end of the day today, you'll see the link and a QR code on the screen to complete the evaluation. It will also be emailed to you at the end of the day today. Once you complete that evaluation, certificates will be sent in 2 batches starting September 21st, I believe, or 22nd, and then the second batch a week later. If you have specific questions for Dr. Pena as he's going through his session, please use the Q&A function on the bottom menu as opposed to the chat. That way questions don't get lost, and we will ask them all at the end. With that, I'm going to turn it over to Dr. Pena. He is one of our board certified child abuse pediatricians here at the Blank Center at Children's. He joined us from Florida, where he was a member of, was the medical director for the Tallahassee Child Protection Team. He also has a special interest in neglect. So with that, I will turn it over to Dr. Pena.
Thanks so much, Angie. Good morning, everyone. Thank you very, very much for joining us for this conference and particularly being interested in the topic of neglect. I know that out of the various forms of child maltreatment is usually not the most interesting one, or the one that folks tend to gravitate towards lectures. So I'm grateful that at least you're interested in this one, and that's why I wanted to title it Reconsidering Neglect, particularly because I'm going to talk about a different approach of looking at neglect, and one that hopefully is based on medical findings, which should help us in terms of finding objectivity in our assessment, which I have found over my years of practice to be extremely helpful. Before we proceed, obviously we have to address disclosures, and here are 3. I'm working really hard on getting some financial disclosures to report, but as of right now, I don't have any. I do want to disclose that this is a sensitive topic, and every time I've presented it, particularly when I have focused on child obesity or failure to thrive, there are multiple disagreements that come up, but I really encourage those, and I also encourage your comments and questions at the end as I continue to work really hard to make this lecture educational, but also interesting. And then the last piece is that really my focus is trying to educate caregivers and colleagues and community partners and hopefully society at large about this really important topic, particularly so that way, even though we may be using different criteria to reach our respective thresholds of neglect, that we at least understand what each other means within our own fields, so that way we can provide the services that we know children that are being neglected or really encountering multiple forms of abuse truly need. I wanted to start with these 2 pictures because these 2 really had a different, I found these folks doing very important pieces of my training and how I wanted to think about this topic. So initially, when I started fellowship in child abuse pediatrics, I can tell you that I didn't think about neglect very much, even though I was going through a pediatric residency, and it was really staring right at me. I couldn't tell you that I knew how to detect it. I can tell you for sure that I was not thinking about it, which seems somewhat paradoxical because clearly I was training to become a pediatrician, and this is a major issue in pediatrics. But as I started fellowship, I really was appreciating more how neglect was looked through a social lens almost exclusively. and how that left very little room for a medical interpretation or a medical lens to look through when it comes to this topic. And again, that is removed from reality. There's a great deal of health implications with neglect, and that's what I'm going to highlight during this talk. The other part is that as I was looking at the different forms of child maltreatment, particularly physical abuse and neglect, I was born in Latin America, and due to generational and cultural norms, I experienced both. I was spanked when I was a child as a form of discipline, thankfully not harshly, but I was. And I can tell you that I didn't give that much thought as a grown-up. Sometimes I even kind of joked about it. But then when I started learning about neglect and started applying it to myself, I realized that I had experienced neglect. And it was particularly emotional neglect. And this was, my father was really against corporal punishment. So his form of disciplining, and as the term, as the definition of discipline is really a learner or to teach a learner, his approach for disciplining me was more kind of a silent treatment. And what I remember particularly was there was a time in which my mother was in the United States and I was living with my father in my country. And there were a 3-week period in which I did something I wasn't supposed to do. I'm not going to share that with you. But he gave me a prolonged silent treatment to try to teach me a lesson. And it was a really difficult week for me at school, a very difficult week for me in martial arts at the time. And I remember that coming to mind or coming to my reflective moment years later, and it stung. It really had a visceral impact on me. And that was my first experience really understanding the implications of neglect, that even though this occurred when I was 10 years old, at the age of almost 40, I was really looking at that moment or that 3-week period and realizing that it did have an emotional impact on me. And again, he was really trying to discipline me. But it really made me appreciate the value of looking at neglect through an emotional lens, and also looking at the long-term implications not being so benign as I once thought. So when we look at chronic toxic stress, we can look at this picture that says, I just want my childhood back. So you can imagine if I can recall just this one instance of silence. I was never berated. I was never really treated in a way that was, that I felt unwanted. But someone that has experienced multiple forms of neglect, physical, medical, emotional, is going to have a devastating impact in their life. And I find that this picture really encapsulates that. So with that brief story, I will move on to our objectives. And here are my main objectives for today is really to look at just helping you evolve in your competency for identifying various types of neglect. Also, really have a better understanding of the extent of morbidity that neglect truly has in children's lives and what we can do about it. And then the last piece, really looking at the medical basis for diagnosing and managing it. So that way, when you see that diagnosis, even if you may not agree based on your legal threshold or your social threshold, at least you're understanding what the medicine is guiding you towards. So this is what I do typically on any kind of clinical question or any kind of contemplation for child maltreatment. Hey, why should I care about this? So we'll start there. And the most meaningful reason or the most critical point that I want to make is that neglect has a really significant impact in child mortality. And I'm going to use this, this publication, and there's an update on this. This was originally from 2016, and as you can see here, the New England Journal of Medicine in 2018 made another iteration to look at specifically firearm-related injuries as really much more prominent than it had been in 2016. So I'm using this to illustrate the following. If you look at each one of these top 10 leading causes of child and adolescent death in the United States in 2016, you will find that motor vehicle crash was at the very top. And this is, again, not new. If you look at firearm injuries, particularly unintentional, then you will find that also within the top 3. If you look at suffocation, And this takes us along the lines of SUID or SIDS. As we look at these two separate categories of infant deaths, it turns out that a great deal of them are asphyxial deaths or suffocation deaths. So you can see that playing a role there. You can see drowning as well. You can see, or you can find drug overdoses, particularly unintentional. So the child gained access to whatever drug, and it was a significant amount, a toxic amount. And then fire and burn, specifically unintentional. So you can see within these 10 leading causes of death, you can find neglect to have a direct implication with each one of these in some capacity. If we're talking about motor vehicle crashes, it's likely because the child was unrestrained and the parent was likely drunk driving. If you look at firearms, I mean, that speaks for itself. If you look at suffocation deaths, really the different initiatives to minimize unsafe sleep tell you that this is a significant problem. And ultimately, once you've taught a parent, and obviously if a parent is sharing a sleeping surface with a baby, the likelihood of a risk or an asphyxial death is significantly high. So you will see why this would be categorized as neglect. Drownings, for obvious reasons, there's lack of supervision. The child is wandering around a body of water. Drug overdoses, we are seeing an increase in that, particularly with the use of medical marijuana and the different gummies. Children are getting into those, and even if they're not dying, they are ending up in the ICU on a ventilator, which doesn't really come without any risk of complications. And then obviously fire and burns, and we see that in the entire spectrum. So again, I wanted to highlight that even though this entire article mentions neglect 0 times, when we dissect the root cause analysis for all of these different child preventable deaths, it turns out that neglect is playing a much more significant role than we may understand, that we may perceive, and obviously that it may be highlighted in a publication. Now, this graph here is meant to illustrate that every time that we start doing metrics on what causes pediatric deaths or deaths in general, it turns out that once you implement an intervention, you see a drastic decline. I don't know if you can see my cursor, but once we start learning about motor vehicle crashes and implementing seatbelt laws and changing the way in which roads are constructed, we see a drastic decrease in motor vehicle crash deaths or related deaths. When we do any kind of safety measure to change the way in which you have firearms in a home, we see a demonstration within society of how many deaths are related to that. So as long as we measure it and we think about it carefully and we're thoughtful about our approach in terms of prevention, really we do have an impact. However, when we look at neglect, and I've been looking at neglect now for years in terms of as a trainee, as a child abuse pediatrician, but also looking at the years before me, you don't see much of a change when it comes to neglect. And the only reason that I have found to date for that is that we are not doing the best job at measuring it. So why is that? So we've looked at that list, and here are some of the outcomes that I wanted to present to you. I'm not going to read all of them, but clearly, if you have significant neglect, you can have permanent disabilities come from that. Obviously, we're also looking at a great deal of suicidality in the teen and the school-age children. And a lot of it, when you're dissecting the rationale for not wanting to fight for themselves or not wanting to really push forward and be able to face adversity, a lot of it is based on there's been chronic emotional neglect. And then obviously the most important one that we're trying to address or prevent is really death. So based on those outcomes and that list that I shared with you about child mortality, I want to share with you now the following. If we're having trouble with the metrics of neglect, why is that? And that was my approach as a trainee during my fellowship training. And as an attending, what I have discovered is that it is extremely difficult for you to understand an entity if we're having trouble measuring it, but also if we're having multiple disciplines look at neglect from different angles, we might have a very challenging time putting all the pieces together as it applies to us. So hopefully after this lecture, you'll be able to see some of those nuances and be able to use the information within your practice or within your discipline and combine it with others to give the best outcome possible for children. So in the National Incidence Study for Child Abuse and Neglect, you'll notice that consistently neglect comes up as the most common form of child maltreatment. This, I can tell you, before I started my fellowship, I was not aware of that. And I'm embarrassed to say it to a certain extent, but I think it really highlights the importance of we need to be talking about this in residency programs and in medical school, because this is a legitimate medical condition, or at least a significant risk factor to end up with a really bad health outcome. So if you look at how poorly neglect is measured and is underreported, and it still comes up as the most common form of child maltreatment. Then when we look at, or when I started practicing and looking specifically at, okay, now I have the responsibility of identifying or at least confirming neglect because someone else was suspecting it, whether it was in the PCP setting or in the ED or in the hospital or somewhere else. Now it was given to me to figure out, hey, is there neglect here? So it forced me to have to think about this differently. So one of the biggest barriers I came across was that the awareness and recognition is highly variable. So often what I would come across is someone in the emergency department, for instance, presenting an injury or presenting some kind of issue about a child, and the first thing that they would mention was that it was an accident. So we will cover why I wouldn't categorize certain things as an accident when we go through the definition. But if everything is already lumped into an accidental category, you're less likely to push yourself to looking at the nuances of whatever incident is brought to your attention. And you will easily go in the direction of accident instead of figuring out, was this preventable? Was this foreseeable? And if both of those are present, then it's likely you're not dealing with an accident at that point. Also, there's a great deal of discrepancy between what the clinicians or whoever was bringing up to me the question of neglect over the phone and what they were writing down. So even though the general pediatrician would tell me, I see plenty of evidence of neglect here, I would never see that in the note. And as we probably know in this group of folks, if it's not written somewhere, it would be very difficult for us to make a social point or a legal point or even a medical point, because we have no point of reference. So we would have to rely heavily on that clinician's discussion about the case over the phone, which is not a feasible component of the assessment. So that was, again, another humongous barrier in being able to confirm that suspected neglect. Then when we dissect the documentation, what you'll find is that even though there would be descriptions provided about the physical exam, then it was not really supported by medical evidence or forensic evidence, if you want to call it that. It was really insufficient. So even though they were pointing out that the child didn't look, let's say, well nourished, there was a missing weight, there was a missing head circumference, there was a missing length or height, depending on the child's age. So you can imagine if they appear a certain way, but you have no objective data to support that, medically, I can't really call it. Then when we look at the social assessments, they were often imprecise and highly subjective. So I would see a myriad of concerns about neglect, about things that is just a manifestation of limited resources, not necessarily that the child is being neglected in a way that they were not protected, they just had limited means. And that really, even though that's neglect, that's almost a functional neglect, that's just circumstances that the family has. That's not a reason to report. Then you would have the legal component of it. So even though multiple thresholds of neglect have been met, it doesn't really rise to the level in which legal intervention is required. So often what I would notice is that someone was really concerned about the child, but as soon as they would learn that there wasn't really anything legally that could be done about it, they didn't seem to have the impetus for documenting or reporting anymore. And this you can imagine from a metric standpoint, it's going to be extremely difficult to identify neglect and to really study it. If as soon as you can anticipate no legal action will be taken, you are deterred from really documenting it. So how are we ever going to learn the extent of this problem if we're not diagnosing it based on a non-medical consequence later on? And also the personal piece in the documentation, different thresholds depending on upbringing, depending on their own access to care, depending on their own access to different means. So all these different variables definitely have an implication, and it's important that we're aware of it. Then the other component that I found extremely challenging was that often we would see physical abuse and neglect. And even though we find them fairly frequently together, the concomitant presence of neglect with physical abuse is about 50 to 65%. So there's clearly a whole bunch of other physical abuse that's happening that doesn't have neglect, or at least that it wasn't identified. But what I noticed in my training was that even though we lump these, really the risk factor for each one of them separately is drastically different. The other part is that you would see that even the caregivers or parents have different tendencies, have different pathologies that really increase their propensity to engage in either physical abuse or neglect. And one that I always bring to mind whenever I'm doing particularly a case of nutritional neglect is that I look at how disengaged the parent is from the child or their level of self-esteem. And what I have found is that most of the time, based on my practice, it actually mirrors what the literature says. Across the board, children that have failure to thrive, nutritionally confirmed, often have moms that are depressed. So believe it or not, and you may know this already, the most common cause of failure to thrive due to suboptimal caloric intake in an infant is maternal depression, not an underlying medical condition. So it begs the question as to these extensive workups that we do in the initial stages of a failure to thrive case, are they really warranted, or should we really be paying attention at maternal depression as the first significant step in our evaluation and then working our way into the medical piece? At least that's the way that I approach it, but I'm not sure that other clinicians do as well. Then the other component that is really difficult is that if you look at the neglect definition, depending on the source that you're using, you're going to find so many variabilities in not only the definition, but you will also find a great deal of variability in the categories or subcategories that they give you, which gives you this sense that neglect is poorly understood. And that's likely the right perception. It is poorly understood. And it is rarely thought about it in the depth of implications that it has. But at least one common thing you'll encounter in all these diagnoses is the term harm and omission. So child harm, caregiver omission, those things are going to be recurrent, but what you will find is that there's a great deal of subjectivity in how these words are being applied. So in this lecture, I'm hoping to give you a more objective approach, so that way, even though you'll be adhering to the definition, you will be looking through a lens that is child-focused, health-focused, and is truly meant to educate. So this is one of my favorite pictures, so I always like to include it there. Just a major fail. So because I trained in Florida, as you can imagine, I looked at the statutes over and over again to figure out where was the nexus between law and medicine. And what I found was that also most of the definitions, that it doesn't matter which state you live in, the definitions for neglect are clunky, for lack of a better word. They seem to hone in on things that are so finite, but it makes perfect sense. The law really needs to stay kind of in a rigid line, so that way people don't lose their children, they don't lose their freedom over something that is highly subjective or really the manifestation of poverty or some other social barrier. So again, if you look at definitions and how you try to apply them to medicine, to social, to law, they're going to be challenging, and therein lies the barrier in us identifying it and calling it when we see it, because again, there are a lot of players that also participate in the care of a child once we identify that. So when it comes to the incidence of neglect, as I mentioned to you earlier, the most common form of child maltreatment is neglect. And yet, prior to me doing a fellowship, I didn't truly appreciate that. I saw really physical abuse and sexual abuse as the most common forms of child maltreatment. I kept asking myself, why would that be the case? Why would I have this perception? Later on, I learned that a lot of other folks also have that perception, but you tend to feel more insecure about your knowledge base. So I did a lot of self-assessments, trying to figure out where did I go wrong in capturing this message. And then I realized that most of what I'm inundated with on TV is typically news about child maltreatment, which would catch my eye since clearly I had a proclivity for looking at this field or looking at this topic. But I never really paid attention at what the research is telling me. I was looking more at what the social presentation of this through the lens of media, and what comes across most commonly is going to be the sensational aspect of child maltreatment, which is primarily based on physical abuse or sexual abuse. So that's why that slide is there, to try to guide you as to, hey, if you haven't looked at neglect as the most common cause, is you're likely being inundated with the wrong message or the manipulated message that I was also victimized by. So when we look at risk factors, and you will see when I discuss more about the spectrum of neglect, risk factors, again, they're not part of a diagnostic criteria. And I always try to emphasize that in any scenario in which I'm given the opportunity. So when we're looking at risk factors, we have to be mindful that because you're at risk of something does not mean that you experienced it. So in looking at the diagnosis of neglect, one has to be mindful that not because someone is lower socioeconomic status means that they are absolutely experiencing neglect or emotional neglect or the different pieces, just that they are at risk for that. I try not to bring that into my diagnosis at any point. I have to be able to prove harm, and you will see that soon. The other part is that you could be very affluent and be a victim of neglect in a different way, primarily emotional, and you will see more examples of that. Lack of support, circumstances, caregiver depression is a big cause. Passive, quiet, or gifted child. So I included all three of these because children that are quiet, quote unquote, they tend to lose the attention they need to the child that tends to be needier, quote unquote. Also, the child that is gifted tends to be expected to perform at a level that they are not developmentally able to. Not because the cognitive domain in your being is advanced means that your social and emotional domain is equally at the same age. So you would have to consider cognitive age, chronological age, and also social or emotional age. And these may be significantly discrepant. So a child that really outperforms other peers on a cognitive level may still need a great deal of guidance, but if they're not getting it just because of the perception that they're above average intelligence, they are going to be neglected accidentally. Also, the puberty or teens, they're expected to do things that the truth of the matter is that they're not developmentally able to pull off just yet. This is particularly the case in children that have chronic medical conditions, like your children with severe asthma or severe diabetes, type 1 diabetes. You'll come across that the parent is, they keep ending up in the hospital with exacerbations or DKA because they are old enough to take their medication and they're not taking it. And, we typically go like, well, the child is engaging in self-neglect. That's not really an appropriate perception, particularly because children are not expected to have an understanding of the chronic implications of their health decisions today. To ask a 15-year-old to worry about a chronic medical condition is the same thing as asking a 2-year-old to worry about falling off the couch when they're jumping around. That 2-year-old does not really care about that. They care about the fun of it. And only until after 30 months of age, they're not going to really have the ability to do self-preservation or self-protection. The same thing with a teen, is just that we're looking at them in a different spectrum of life. That 16-year-old yet does not understand the health implications of taking good control of the diabetes is developmentally appropriate. And because it's developmentally appropriate, it would really not fall under the category of self-neglect. It would fall under the category of medical neglect by the parent, not by the child. And then obviously children with special needs, both medical and nutrition, and then all the medical equipment that is required. So I'm giving you this list and spending a great deal of time so that way you can appreciate where there could be potential societal gaps that may lead to an unpredictable and highly detrimental view of neglect. Then the other component that we have to keep in mind, and you will notice at the very the right lower corner, I put difficult there, is trying to remind us about really each one of these slides is trying to hone in on why is it difficult for us to pick up on neglect. So if you choose to review these slides in the future, this is kind of guiding you through that. And the presentation of neglect is highly variable based on age as well. So depending on which patient I have in front of me, you can imagine that the red flags I'm looking for to pick up on neglect have to be different. This is the only medical condition in which I have to think that way. Even though we see a lot of different distributions for medical conditions in children, they tend to be isolated to a group. So, there's one that goes from 6 months to 6 years. Febrile seizures are another one that kind of falls under that piece. So we tend to kind of have this cohort of babies that we worry about something, and then we stop worrying about that. But when it comes to neglect, it really can be across a lifespan. You just have to know how it's going to manifest within that group for which your patient or your client belongs to within your particular assessment. So here are different things that you want to consider, particularly your toddlers. If you're looking at a toddler that has come in with an ingestion or has an animal bite or has a burn, you really should be looking at, was that incident preventable, foreseeable, and that if those two are present, you really are kind of walking that fine line of neglect. The same thing if you're looking at infant, lack of stimulation. So looking at developmental milestones not being achieved, or looking at nutritional issues like really suboptimal weight gain. These are your red flags to be considering neglect sooner rather than later. Then we're going to talk about the spectrum of neglect. And this is one of my favorite aspects of neglect, just because it pushes me to think outside of the blocks that I have been presented with. And also what the literature covers. A lot of this stuff, the literature covers it, but we have a different twist now with technology. And I think it can create a great deal of misinformation, but it also helps us significantly at looking at the differences, like what I'm pointing out here. In 1975, how children were in the back of a truck, and I was one of those kids, even though I'm a 1980s child. But in 1980, this was very acceptable. That is clearly not the case anymore. When we look at today, the amount of safety that we try to emphasize with families is pretty significant, and yet we're still seeing a great deal of failure. So when we look at specifically protection, one of the things that I will highlight, that the top on the 1975 one is an example of, if you're failing to protect one of these kids, if they fall off that moving truck, they're going to get injured. There is harm there. And it's a lot more palpable, a lot more immediate, if you will. But when you look at overprotection, typically the spectrum that goes into excess, it doesn't present in the acute stages. It really manifests later in life. And I believe that's one of the major challenges in calling it out when I see it, unless the child has some significant red flags. But what I have found is that in the child that is being overprotected, typically the way in which they are developmentally going to make up for that is that later on they're going to engage in really high risk behavior, trying to get a taste of that danger, that adrenaline surge that they were never allowed to engage in earlier in life. So then now that they are faster, stronger, and much more able, you'll find them to end up dying because they have yet to achieve the developmental awareness of safety, and they're just doing things based on the impulse of being a teen. So in some ways, the parent is responsible for having to kind of titrate experiences for that child, so that way they are able to experience pain. They are able to experience failure in a healthy way, so that way they can make better decisions that are more developmentally appropriate based on their stage. When we look at also different forms of, or within the spectrum of neglect, looking at food and looking at approval and discipline. This is one of my favorite examples to use because a lot of folks have watched Harry Potter. But if you look specifically at food, you can see how oversized Harry's clothes are. He's meant to look like a child that is malnourished. So here's that spectrum of neglect. Meanwhile, his cousin, who is loved almost to a pathological level and fed definitely to a pathological level, is exhibiting obesity. And also his behavior is highly unkind. He really has no regard for Harry's well-being. He really has no consideration. He goes sometimes even out of his way to be unkind to Harry. And part of that is usually because you're not being guided as to how to approach the world in a sensible manner. So you believe that the world owes you something, and you fail to recognize that you owe something back to the world. So again, that is looking at excess. And even though it's somewhat obvious in this picture, you have to be paying close attention to his behavior and to his body habits and understanding the health implication and how he was able to get there. So again, one of the reasons why I like to use this picture is because it shows us that spectrum. The other component is, if you look at Harry, whenever he goes to school, he is often very insecure. His self-esteem is constantly a barrier to his performance. So you can imagine, if you are deprived, that child tends to either go in the direction of being extremely withdrawn or quiet, quote unquote, and they typically don't reach their full potential, even though they may have the skill set or the gift to be able to do it, primarily because of the environment impeding them from reaching that potential. And that's often through some kind of caregiver omission. Then if we go into this other example of looking at guidance and approval, this is the famous case of affluenza with Ethan Coach or Couch, depending on how you like to pronounce it. But this is an example of a child that at 16 years of age, he was drunk driving and killed these 4 folks that were in this public place. This child, one of the biggest things that was brought up to society's attention was that he got away with it, that he really did a minimal amount of, there was minimal punishment for what he engaged in. And when you look at that, you'll notice that his parents also seem to have the same kind of sociopathological approach to their behavior. And likely they taught him to behave similarly. So once again, we're seeing a dysfunctional excess and over celebration of whatever this child did. And eventually it became a pathological behavior that injures folks. So again, deprivation is neglect, but also excess has a great chance of being neglect. It's just, how are we picking it up? Are we even considering a witness in front of us? And if you look at a child that is constantly being celebrated over the most insignificant things, often when they grow up and they don't have that level of, compensation or celebration, they tend to be depressed because that's all they knew. So now their self-esteem suffers because of that. So once again, self-esteem is being affected because of 2 different ends of the spectrum, the excess piece or the overindulgence part. And even though affluenza is not a legitimate scientific or medical diagnosis, spoiled child syndrome is, and very much there are overlapping features for both. When we look at neglect types, make sure I'm doing well with time. Yes, when we look at neglect types, you'll notice that a lot of it is what we read. And depending on how that source breaks it down, you're going to pick up some forms of neglect, and sometimes you will not. But the one piece that I want to always highlight to you is that what we know in the literature is only the tip of the iceberg. Is what we don't know that's happening in the homes, is what we don't know that's happening within ourselves. So if you want to reflect on moments or instances in which you felt that you experienced neglect, it may make you read differently. It may make you look at this topic differently as well. Hopefully you'll take me up on that challenge. I have found a great deal about myself by doing that. So here are the most practical neglect types that I've come across in the literature. And if you wouldn't mind looking at this slide and quickly thinking, which one do you think is the most common form of neglect within these different types? I'll give you 5 seconds to look at these. And if you guessed that the most common type of neglect was educational, then you got it right. And I was shocked when I learned that in my readings back in the day. And then when I stopped to think about it more carefully, I realized, no, it actually makes perfect sense. And the reason why it does is because educational neglect is really following truancy, failure to enroll, and attention to educational needs. All of these are going to manifest in a very binary way. Are you at school? Yes or no? Did you enroll? Yes or no? Are you paying attention to your child's educational needs? Yes or no? There's not really all these little nuances and variables that we use in all these different forms of the other types of neglect. It's either you're there or you're not, and that is being measured as a present or not present. And then those metrics are provided. There's very little contamination when you have something that is binary. So as a result of it, educational will be the most common form of neglect because it's being measured. So I wish that we could do the same thing into all these different forms of neglect. And in my practice, that's what I'm aiming to achieve. And to a certain way, I have. In other ways, I'm still working at it. So here are some things that I hope that after today, you're able to consider, and hopefully that brings change to your work in a meaningful way. So here's how I go about diagnosing neglect. The first part that I consider is, did harm occur? So if I found that the child is in the hospital and has a fracture, or has a burn, or has a bite, or a cut, or was sunburned, there's harm there. The child is feeling pain that was preventable, possibly foreseeable. So immediately, there's my check. The second one, was there a caregiver omission? So is the child now in pain, or did the child sustain harm over something that the parent failed to do? Not intentionally, this is not about what the parent meant to do, but was there a failure on the parent to do something? And it could be for various reasons. It might be that they just didn't have the resources to change the course of that. It may be that they just didn't have the education to do that. Or maybe that they were just not home. God knows, but was there a failure on the caregiver? And if that's present, then check. Then, was the incident foreseeable? If it's foreseeable, it's likely preventable. It's not always the case. But if it's foreseeable and it's preventable, then I check those. If all those have occurred, then borrowing from personal injury law, I started saying, okay, then we do have neglect here. And if you look at all the different definitions, irrespective of the state, even in all the wordiness behind it, you are able to discern that from a legitimate assessment or investigation. And if that's the case, if you have yes for all four, that the neglect diagnosis should be made. But the goal is not meant for punitive purposes, like what personal injury law would really confront. Really, for our purposes, is education to prevent future incidents or death for this child or their family members. So even if the caregiver omission was something that the parent was just lacking education, then there's our opportunity to educate. If the parent really failed to protect the child because they just don't have the means to have a home that is childproof, let's make note of that and call it neglect, so that way we can show society how frequently these things are happening, because really the different tools to have a child-proof home are beyond many's abilities to afford it. So if we don't measure this and we don't highlight where we're having problems, then how are we going to be able to move the needle in any direction? So here are some examples of things that I've come across in the physical neglect. And again, I'm not going to go over definitions per se. You can always read those. But each one of these photos that I have here, I have treated children for these problems in one scenario in my medical career. So children that were left unattended in a hot car, children that came in with horrific sunburn for not having sunblock on, obviously the failure to thrive cases. I had a case in which the child was wrapped around the chain and had 2 fractures from how the dog was moving. Again, preventable, foreseeable, a failure to ensure the child's safety. I've had children that have ingested different substances. We've had children with multiple, not even just one, but multiple scenarios of coming to the emergency department after being bitten by an aggressive dog at home. And still the dog was kept in the home. So again, these things are preventable, they are foreseeable, they should be called neglect, and we should do something about it to prevent a really bad outcome. Then we get into nutritional neglect, and I'm only going to go into nutritional neglect to give you more of the medical basis for it, because we have different ways in which we can objectively track neglect nutritionally. So the first piece is that by definition is really an imbalance between nutrient requirement and intake, the cumulative deficits of energy, whether from protein or micronutrients, and ultimately it affects growth. But we can make the same point for childhood obesity. Is an excess in the amount of nutrients that the child really needs, and that's going to manifest in different ways, but it is still there. When we're looking at failure to thrive, look at the different variables. If I have a breastfeeding child versus if I have to consider a formula fed child, the different questions. And if we're dealing with a child that gets both, the history needs to be expanded. So each one of these bullets, and again, this is just to make a point, would tell me a different variable. And if I miss one of these things, or if we miss one of these things in our investigation, we're going to have a little bit of trouble being able to substantiate our concern for nutritional neglect from suboptimal caloric intake. So it's really important that we give ourselves credit for the fact that this is a complex entity to investigate, to confirm, and then we address it accordingly. This is just giving you examples of the only way that you can, over time, understand whether you're barking at the right tree, if you will, is if you can follow the child longitudinally, and many of us don't have the opportunity to do that. So when we do have the child in front of us, we must use as many data points as possible to be able to prove our suspicion or to highlight that someone needs to keep an eye on this child so that way we can prevent something from occurring that would be detrimental to their health. Again, giving you just variables. Now we're dealing with a toddler population. Then we're going to take a completely different history and try to understand this child now at this age and see whether there was something underlying before as compared to now. All these variables make the investigation, make the assessment of failure to thrive for suboptimal caloric intake or nutritional neglect extremely difficult, and we need help. So this is how the documentation, the constant communication between the different agencies can really play a significant role in implementing the right services for families if we identify neglect. Then looking at that spectrum again, because it's important that we do so, I get lots of phone calls for this, the deprivation piece. I've only gotten a few phone calls in my time as a child abuse doc, now going on almost 10 years. But I've only handled, I believe, about 5 cases of childhood obesity presented to me as medical neglect, even though there should be a lot more than that. Now, the reason why that's really important is not only have we seen an improvement in capturing these cases, at least from a child obesity standpoint, and you can see that the ICD-10 does a really good job at encompassing a lot more about medical neglect or about childhood obesity. But what we tend to have issues with is typically how we interpret that information. Because we see the child as being overweight, many folks consider the child to be, oh, he's just really healthy, 2 thumbs up for that parent. But the truth of the matter is that there is a failure there to properly supervise caloric balance, and that is not inconsequential. Then we also have failure to follow medical advice, because often these parents are being told by a pediatrician or whoever is caring for that child's health, hey, we need to do something about diet, we need to do something about increasing activity, and they're failing to do that. Ultimately, we will have the surfacing of comorbidities, with some of them with immediate repercussions. And at that point is when now folks are starting to think of neglect on these extreme ends of the spectrum. But we really should have highlighted the issue earlier in the process so that we would have much more success in interventions and really changing the trajectory of their health. Now, if you look at these two, the impact of nutrition and neglect, look at the typical things that we encounter when we're looking at underweight and deprivation versus obesity. So clearly, if we were to looking at comorbidities as a proxy for reporting or for implementing interventions, obesity should be the one that's leading to a lot more phone calls to our service, not necessarily failure to thrive, even though both of them obviously should be presented to us. But I'm making a point that obesity is not as benign or trivial as one may think based on society's perceptions. And then look at the different comorbidities that we encounter in children, and all of these, ultimately the literature points out that a child that is obese has a 50% chance to be an obese adult, and the likelihood of death, premature death specifically, is significant to the point that they can die 14 years earlier than their anticipated age if they did not have the comorbidities related to their obesity. So just to point out, in terms of assessing harm for intervention, particularly in the childhood obesity group, you'll notice that this is when we come across children in our clinic. They have hyperinsulinism, so they're approaching that piece in which they are going to be a type 2 diabetic. They're telling you that they're snoring at night. We're also seeing some elevated liver enzymes. And that's when the documentation starts. And really, we need to be aggressive about this, because the truth of the matter is we're not going to see much intervention from society or the legal sector until impending danger thresholds are being touched on. And obviously, we don't want to do that to children. We don't want to wait that long to intervene. So this is just to really present to you, taking the approach of, yeah, let's not be overly aggressive now. We don't want to be offensive. We don't want to be, prejudiced about whatever the family does. It does have an implication. We need to just really come up with a different narrative that does not come off as accusatory, but informative. And when we get into supervisory neglect, ultimately, the piece that I want you to take with you is that the most common diagnosis I give to parietal skull fractures is supervisory neglect, not abuse. And the reason why is that often infants are being left on top of an elevated surface. And then for 2 minutes, the parent goes to make a bottle, they go to the bathroom, they go somewhere else with a baby that has proven over the past month that they can roll on the bed. Falling off that bed onto a hardwood floor and sustaining a skull fracture is harm. The parent engaged in a failure to ensure their safety by not putting them in a place that they would be guarded. It was foreseeable, it was preventable. It is neglect, but rarely do you actually come across that perception. So it's important that we start looking at this from a preventive standpoint and understanding, hey, if it's preventable and foreseeable, we have an opportunity to educate. The other part is looking at your helicopter parenting. I think saying helicopter parent is not nice. So we just use helicopter parenting. And the reason why, hopefully now that you're seeing spectrums of neglect, is because this human being here, this little caricature, this graduate does not look happy. He looks more concerned than anything else. And it's because this helicopter parenting has not allowed him to develop the skill set for self-sustainability or self-survival or self-care. They always have to rely on someone else. So in the process of you removing barriers from the child's life, really the role should have been that you are going to teach the child how to navigate the world, so that way in your absence they can be successful and they can really take care of themselves. In failing to do that, you are engaging in neglect in some capacity, because ultimately we're going to see the implications of that for that human being, and they're not going to be positive. Then when we get into medical neglect, here is the criteria that I consistently use. And if you want to take a screenshot or be able to use this in the future, I highly advise you that you do, because it's really objective in so many different ways, even though the nuances can be somewhat subjective. But this is typically how I arrive at the diagnosis of medical neglect. And for the sake of time, I'm going to move forward. Again, this is just to give you an idea of how the medical neglect diagnosis is really achieved. And ultimately, it revolves around, was there harm? Is it foreseeable, preventable, and did the parent fail to provide something for the child? If those four are there, irrespective of the type of neglect, we are going to be able to call it, and hopefully we'll be able to do some level of intervention that will be highly beneficial for the entire family, not just the child. And then in preventing medical neglect, here are some of the things that there are red flags all over, like having a first-time parent, having a parent that doesn't really have great coping skills with a child that has above average health needs. The writing is on the wall. It's just, are we paying attention to these red flags? So that way we can get ahead of the game and be able to provide education in a timely manner to improve health outcomes for that child. Then when we confront emotional neglect, we walk a really fine line with psychological maltreatment. And for that reason, I have them in this slide like this. These are extremely difficult to diagnose, particularly because you have to look at development and how it has changed. And typically a snapshot of when we're looking at this child for that assessment is insufficient information to arrive at such a meaningful diagnosis. But based on the example that I gave you about my own childhood, it's important that we keep in mind that this really does have a significant implication in someone's life, and that us not detecting emotional neglect does not mean that it is not happening, and does not mean that we shouldn't be studying it. And then when we look at educational neglect, we already touched on this. The point I would like to make about this is, if we try to use the binary approach, if you will, of educational neglect, we will find some level of objectivity. And hopefully with that 4-tier approach that I presented to you, you can either start seeing where we're coming from when we diagnose it from a medical standpoint, or you can perhaps apply it to your own discipline to see how objective is your assessment when you're doing your investigations. And hopefully this will be a good guide for you. Here's my evolving approach. So once I confirm the diagnosis, I try to figure out where within the spectrum of harm am I dealing with, so that way I can provide some prognostic clues and also some meaningful recommendations. Also assess the caregiver omission. Is this an educational issue? Is this a resource problem? Is this just the function of circumstances? And I try to address that. And I try to give recommendations, again, that are kind to the parent, as they should be. Screen for other forms of neglect. Remember, wherever you find one form of maltreatment, you're going to find others. It's just how keenly aware are you that there are other pieces here to contemplate. And also determine the appropriate interventions. Clearly, separation of parents and children over something like this is an extreme approach. Education, safety planning, additional workup, all these different strategies can be combined to really come up with a good outcome and provide the families with the resources that they need. Here are some clues on how to select interventions. Here are some recommendations, and again, this is just for you to review on your own time if you wish. And here are some: prevention is the best intervention. Here are some things to keep in mind, particularly in my case, for my practice. If I look at first-time parents that I'm detecting depression, a history of drug addiction and mental illness, financial limitations, whether it's excess or excessive affluence, and trauma as well. So children that graduated from the NICU, they're going to have different components of their medical care and trauma for the parent, that both of them can be combined to create a scenario that could potentially be neglectful for that child. Again, within the same spectrum, you can have someone that is excessively protective and excessively worried about the child, and that's going to create other concerns, and the child may not attain their full potential because of those limitations. Again, the sooner we identify this, the sooner we can intervene, educate, use our community resources, and help from our colleagues, as well as helping them as well. Here are your three major take-home points. Again, feel free to refer to those in your own time. And with that, I'll take questions. Here are my two girls, Luna and Lily, and my two boys, Lucas and Landon. Just sharing a little bit about myself, I guess. All right.
Great. Thank you so much, Dr. Pena. There are several questions. Some we may not be able to get into because the dynamics are quite unique. I do want to say I've seen this pop up a couple of times in the chat. The slides will be available on the PCA Georgia website on Friday, so you will get access to them, just not immediately. One of the questions was, how do you determine or describe harm or high risk for harm for educational neglect?
What a great question. So with educational neglect, the most significant harm is going to be social. This child's ability to reach their full potential. Remember also from our own childhood that when we didn't get it right, we almost had a target on our back for bullying. And all these things are really more from a self-perception. So if you don't view yourself as being an intelligent person or someone that is competitive, it really does have an implication with your psyche and your self-worth. And that's where I found that harm would be present in educational neglect.
Okay. Does lack of, quote, emotional food lead to nutritional neglect, then become a vicious cycle? Child learns helplessness when emotional and or nutritional needs are ignored.
Yeah.
That's basically a question. Does this sort of perpetuate itself into a cycle? Emotional needs aren't being met, nutritional, then that leads to nutritional needs. Is that?
Absolutely. I think that's a great way of conceptualizing all of this. If you found one form of neglect, as I mentioned, you're likely going to encounter others because the parent themselves is failing at one component of their parenting, and the likelihood is because they haven't had the right modeling to do a better job. So it's going to carry on, it's going to almost like cross-pollinate into other forms in which parenting should really be optimized. So if they're engaging in that emotional deprivation or failure, there is likely going to carry on to other forms like nutritional. Absolutely.
Okay. Another question, given that some of the interventions for neglect may necessitate a parent's change in their value system, what suggestion do you have for addressing this aspect?
Wow, these are great questions, tough ones too. I think the most significant piece that I can personally share is that the way in which I gather histories and give advice is extremely non-assuming. I don't really make assumptions about their circumstances. Everything I leave on them, and I present a very genuine approach to gathering the history, so that way parents know that my intent is to learn about them as much as I can so I can help them. Once you understand parents' motives, once you understand their value system, the negotiating piece is really based on mutual respect, and often I will ask for permission to give them kind of guidance. Hey, do I have your permission to share how I think you could have done this better? So it can create a very respectful and kind approach to correcting whatever they perceive as something that they didn't do correctly, but they had their reasons. So it would be morally arrogant for me to say, you did that wrong, and here's why. I think having a narrative that's a lot more inclusive and collaborative is really the way to go.
Okay. Any thoughts on the free-range parenting movement as a pushback against overprotection and as a means to allow the child to take reasonable risks?
Wow, what a great group of folks and great questions. So my views on it is, are that one, anything in excess, whether you're talking about deprivation or providing excess surveillance, is going to be detrimental. Once again, I'll use what I shared during the lecture. Our job really as parents or as grown-ups is really guide children through how to navigate the world, not to clear up the barriers for them. There's a great deal of value in them confronting issues, but you have to be mindful that not every brain is developmentally ready to self-protect and learn. So there has to be some adult or some caregiver surveillance, so that way the person can watch the child prevent an injury, but also be able to go in an appropriate developmentally, in an age appropriate way, explain to the child some of the implications of their actions. So I'm again against anything that is excessively surveilling or excessively detached. We really should be there to provide guidance.
That is unfortunately all the time we have. Dr. Pena, are you okay if I share your email address? If people have other questions, they could send them?
Absolutely not.
Okay, I'm going to put it in the chat. If you have questions that we weren't able to get to, please feel free to email Dr. Pena directly to get those questions answered. Thank you so much for joining us. Just a reminder that we are going to end this session, so you will have to go back into the Cadence link to go to your next session. Again, thank you so much, Dr. Pena. This was wonderful information.
Thank you.
And we hope you enjoy the rest of your sessions.
I will. Thank you. Thanks, everyone. Have a great day.